everyone. Welcome to today's webinar on liver disease and South Asian communities. My name is Paula Neves, and I'm the lead for the Center for Living Organ Donation. We have a terrific session today with Dr. Natasha Chandok, who's a hepatologist at William Osler Health Center. And we also are very fortunate to be joined today by Sonali Pendarkar, who is a registered social worker at the Ajmera Transplant Center. We will also be addressing your questions as we go. So a reminder to visit slido.com, and the code is liverhealth. I will turn it over to Dr. Chandok to provide an overview of liver disease. Dr. Chandok?
Thank you, Paula. Good afternoon. It's my pleasure to be speaking to you today to provide an overview of liver diseases. The outline to this talk will begin with a brief introduction to the liver. It's certainly a very fascinating organ, and it provides a variety of important functions in our body. I'll then discuss clinical manifestations of liver diseases. Thirdly, I will touch on the epidemiology of liver diseases in the South Asian community. I will then have a small session on the treatment of liver diseases, including liver transplantation. And I will close my talk on some thoughts on prevention of liver diseases. So the liver is a very fascinating organ. It's about 3 pounds and about 14 centimeters in length in the average adult. And it does a myriad of important functions in our body. Firstly, it makes bile, and bile is a substance which allows us to digest fat and absorb fat-soluble vitamins in our small bowel. The liver also makes the majority of proteins in our body, the most important of which is albumin. And in addition, it helps to produce cholesterol and regulate cholesterol. In addition, the liver helps us balance sugar levels in our blood as well as amino acid levels in our blood. It is also an instrumental organ in hemoglobin processing, and it's a major storage site for iron. One of the very important functions of the liver is to detoxify our bodies. So the liver converts nitrogenous wastes into a product called urea, which is something that we can excrete out. And when the liver is not working, patients will have some major consequences on their central nervous system due to an abundance of nitrogenous wastes that haven't been processed. The liver is also an organ which metabolizes the majority of drugs and toxins. Additionally, we often don't remember this, but the liver is a very important organ in our immune system, and it's responsible for making immune factors which help us overcome infections. And finally, the liver helps conjugate and metabolize bilirubin from red blood cells. On the right, you can see a diagram of the liver. The liver can be divided into the left lobe and right lobe by a ligament called the falciform ligament. Another way to describe the anatomy of the liver is via sections, and there are 8 sections in the liver and 1,000 lobules in the liver. So I now want to give you an overview of what chronic liver diseases are. And in bold in this slide are the most common liver diseases. By far and away, the most common liver disease in the world is non-alcoholic fatty liver disease. And it's very hard to believe, but we didn't recognize this disease until the early 1980s. And we now realize that we are in a global pandemic with this disease. The second most important common liver disease in the world is alcohol-related liver disease. The third most important liver disease from an epidemiological perspective is viral hepatitis B and C. And you can see on this slide, there are several other types of liver diseases that I would treat as a liver doctor, or transplant programs would potentially see for a possible need for transplantation. These would include autoimmune liver diseases, genetic liver diseases, vascular diseases, and even cancers, unfortunately. I did put in bold the most important liver diseases which affect our society. And I also bolded hemochromatosis because that is a very common disease that primarily affects Caucasian patients. I now want to talk a little bit further about non-alcoholic fatty liver disease. This disease is diagnosed on a sonogram. Fat looks white on an ultrasound, so that's how it would be identified. And this disease, based on population studies in North America, affects approximately 1 in 5 adults. And unfortunately, it is also very prevalent among children and adolescents, primarily because of the obesity epidemic. Non-alcoholic fatty liver disease is associated with a variety of diseases, which are part of the spectrum disorder called metabolic syndrome. And metabolic syndrome refers to several diseases which are all related to obesity. These include increased waist circumference, dyslipidemia, insulin resistance, hypertriglyceridemia, and type 2 diabetes. Despite how common this disease is in our society, unfortunately, at this moment in time, there are no pharmacological therapies for non-alcoholic fatty liver disease. So our focus on these patients is to control all of their metabolic risk factors and assist them with weight loss. This disease, non-alcoholic fatty liver disease, is the most common chronic liver disease in the world. And it is now the most common reason that patients need a liver transplant. I've been a practicing hepatologist for just over 10 years. And when I was training at that time, 10 years ago, hepatitis C was the most common reason for transplant. And things have changed dramatically because of breakthroughs in hepatitis C treatment, and also because of our aging population. And as we age, the natural history of non-alcoholic fatty liver disease is unfortunately in some patients one of gradual progression. On the right of this slide, you can see a picture of a healthy normal liver, which is the purple triangle at the top. And below it is a yellow structure, and that is what fat looks like. A fatty liver is a yellow liver, and under the microscope, when you look at it, you'll see globules of fat. There are actually techniques where we can even quantify the percentage of fat that people have in their liver. And again, it is not normal to have any fat in our liver or any scar tissue in our liver. Some people with this disease, unfortunately, do develop cirrhosis over time. And we're really not sure at this point why some people stay at mild fatty liver and others progress. And that is a work of ongoing research. I now want to talk to you about another very important disease in our society, alcoholic liver disease. And alcoholic liver disease actually encompasses several diseases. So as a hepatologist, I would be looking to further stratify patients with this disease. So for example, patients with milder alcoholic liver disease have something called alcoholic steatosis, which means a fatty liver without any scar tissue. Some patients will progress further onto that stage and develop something called alcoholic steatohepatitis, which means a fatty and inflamed liver due to alcohol. The third stage of this disease is a very dangerous stage called alcoholic hepatitis. And in this situation, in severe states, patients are often admitted and they have very high mortality rates. They may present with jaundice and other signs of liver failure. The final stage of this disease is, of course, cirrhosis. And alcoholic liver disease is complicated. It doesn't just get caused by drinking excessively, but we know patients are at risk for it if they're drinking over 30 grams of ethanol a day. And just for your reference, a standard unit of alcohol has 14 grams of ethanol in it. So as little as 2 drinks a day can predispose someone to developing alcohol-related liver disease. But we know that this is also a strongly genetic disease. So for patients to develop alcoholic liver disease, they do have as yet unidentified SNPs of various genes that predispose them to this condition. Statistics have indicated that approximately 20% of heavy drinkers will get a fatty liver from alcohol, and approximately 40% of patients who develop alcoholic hepatitis will go on to develop cirrhosis. Overall, 10 to 15% of patients who have chronic alcohol misuse do develop cirrhosis. The diagram on your right shows an abdomen of a patient with alcoholic cirrhosis, and you can see the tremendous amount of fluid this individual has. He also has dilated veins in his abdomen, and this is something that we call caput medusa. And what caput medusa is a inability of the veins of the abdomen to drain because of high pressure within the abdomen due to cirrhosis. And that's from portal hypertension, which I'll touch on a little bit later on. I now want to talk to you about viral hepatitis B and C. Hepatitis B and C are both common diseases. The World Health Organization has provided us all with a global challenge to reduce the prevalence of this disease by more than 90% by the year 2030. And we have a lot of work to do in our country to achieve that goal. Hepatitis B is a DNA virus. It can cause both acute liver failure as well as chronic disease, including cirrhosis, liver cancer, and a variety of extrahepatic diseases. Believe it or not, 2 billion people on our planet have either had hepatitis B in the past or currently have it. It's estimated that approximately 250 million people on our planet currently have hepatitis B, and very sadly, over 850,000 people die every year of hepatitis B related diseases. And this is particularly heartbreaking because this is a disease which we can fully prevent and easily treat. As you know, in parts of the developing world, vertical transmission is the most common way this disease is spread. And here in the West, percutaneous and sexual transmission are the most common ways this disease continues to afflict patients every day. Hepatitis C is a RNA virus. Approximately 71 million people in the world have hepatitis C, which corresponds to about 1% of our population, including 1% of Canadians. Canada is in a relatively low prevalence area, but other areas have much higher prevalence. The highest prevalence in the world is in Egypt, where over 8% of the population has hepatitis C. The natural history of this virus is that 30% or so of patients who get it will clear it, and around 80% of patients will develop a chronic infection. 30% of people with chronic infection will eventually develop cirrhosis, and one's risk of cirrhosis will be accelerated if patients have other liver diseases, including alcohol. What is amazing is that we are now living in a time where hepatitis C is easily curable, and curing hepatitis C not only prevents liver-related mortality, but actually improves overall survival. I now want to touch a little bit about the epidemiology of non-alcoholic fatty liver disease in South Asians. On the left, you see a map of South Asia, and studies have suggested that the prevalence of this disease in South Asians is extremely high. For example, studies in Pakistan have suggested the prevalence is as high as 70%, which is very alarming. We're not sure why fatty liver is so common in South Asians, but it is believed that there are genetic polymorphisms in this group of people, as well as perhaps some socioeconomic factors. Interestingly, fatty liver is seen in South Asians at a much lower body mass index than in Caucasian counterparts, which really underscores that there's more than just obesity that causes this disease. South Asia, unfortunately, appears to be an epicenter for NAFLD. This may be due to an increasing sedentary lifestyle in South Asia, especially with socioeconomic growth and affluence. There's also concerns that dietary westernization and urbanization have led to higher rates of this disease. It's really important that here in Canada, we focus on fatty liver disease in our South Asian population as we do have a lot of South Asians living here, 5.6% of our national population. I now want to talk about alcoholic liver disease. This is a very fascinating topic for me. Based on studies that we can gather, it doesn't appear that alcohol use is very high in South Asia. For example, in a study in India, the World Health Organization estimated that only about 26% of males drink alcohol regularly, as compared with the vast majority of European male counterparts. It does appear that both South Asians and other ethnic groups, if they do consume alcohol, consume similar amounts of alcohol. However, there is a striking difference between different ethnicities and the development of alcohol-related liver disease. Studies have suggested that South Asians are much more likely to develop alcohol-related liver disease as well as alcohol-related cirrhosis than Caucasian counterparts. The cause for this is unknown, but it likely involves genetics and other factors. Here in Brampton, where I practice, it's been very alarming for me to see the number of young South Asians in their 30s and 40s who I'm diagnosing regularly with alcohol-related liver disease. And I do think it is a public health crisis that we need to start addressing. I now want to talk to you about clinical manifestations of liver disease. The sad part about liver disease is that typically patients do not have any symptoms until their disease is very advanced. And this is frustrating because it means that patients won't be picked up earlier and have the opportunity for early intervention. Liver diseases commonly cause non-specific symptoms. These may include anorexia, fatigue, and weight loss. When people develop cirrhosis, they develop a lot of very dangerous signs and symptoms. These may include internal bleeding from large varices, which are very similar to varicose veins, which develop in the esophagus and stomach. And these veins have a lot of pressure in them because of the high pressure that cirrhosis produces in the portal circulation. And these veins may burst and cause life-threatening bleeds. Patients may also develop something called ascites, which is fluid accumulation in the abdomen. Additionally, patients may present with yellowing of the eyes and skin, which we call jaundice, and even confusion, which we call encephalopathy. As liver disease progresses, it will actually produce multi-organ failure, including kidney failure, lung failure, and even heart failure. I wanted to show you some pictures to really illustrate the terrible circumstances which patients with cirrhosis live with. In the top left picture, you see a gentleman standing. You can notice he has a lot of muscle wasting, and he's carrying a tremendous amount of fluid in his abdomen, perhaps 15 extra liters or 10 or more kilograms in weight. You can imagine how difficult it is for him to walk, to breathe, to eat, even to tie his shoes. For somebody like this, they need a lot of healthcare resources. We often need to see the patients regularly and drain their abdomen with a needle so that they can have some degree of quality of life. The top middle picture shows you the palms of a patient, and you can notice these palms are red. We call this palmar erythema, and this occurs in cirrhotic patients because of dilation in their capillaries, which is caused due to a high level of estrogen in the blood. The liver is involved with many functions, including estrogen processing. The top right image is a very dreadful image for any liver doctor. This is a bleeding patient. This is an endoscopic image of the esophagus. Normally, you would not see these bulging blue veins with blood coming out of it, and this is bleeding varices. The bottom left image shows you a hand which is stretched out. Patients cannot, with cirrhosis who have encephalopathy or high degree of toxemia in their blood, they cannot keep their hand extended and it will start to flap. And we check for this when we examine patients, and this is called asterixis, and it is a sign of hepatic encephalopathy. and an indication of liver failure. The middle bottom image shows a gentleman in the ICU. Very commonly, patients with cirrhosis do find themselves in the ICU. This patient has a lot of tubes and lines in him to keep him alive. You'll notice if you look carefully, he's wearing a blue helmet, and you might be wondering why someone in the ICU is wearing a helmet. He has a special tube in him called a Blakemore tube because he was having severe bleeding from varices, which could not be controlled. And as a life-saving measure, a Blakemore tube was inserted into his esophagus and his stomach, and we blew a balloon up in the stomach, and we anchored that tube, the Blakemore tube, to his helmet to provide some tension so that the balloon will abut against the gastroesophageal junction and hopefully provide some tamponading to decrease hemorrhaging. This is clearly a very risky situation. The final picture on the lower right-hand corner of this slide is just showing you a partner of a patient with cirrhosis. And you can only imagine the toll this disease has, not just on our patients, but on their family members. I now want to briefly talk to you about my experience in Brampton, Ontario. Brampton, as you know, is a very large city in Canada, the 9th largest in fact. It is the second fastest growing city in our country, and it is one of the most diverse places in our country. 66% of the population is a visible minority, and approximately 40 to 45% of the total population is from South Asia. I gathered some data from our hospital, Brampton Civic Hospital, just to give you a snapshot of what we're dealing with here in Brampton. And I want to present this information to you just so you get a sense. This bar graph is showing you the number of admissions we have per year for patients with a primary diagnosis of liver failure. And this data does not include patients with a secondary diagnosis of liver failure. Every year, we're admitting approximately 400 patients to our hospital, and we're about a 620-bed hospital. Alcoholic liver disease patients are depicted in the blue bars, and they represent about a third of our admissions for people with liver failure. This slide is giving you a sense of how sick our patients are with liver disease. They are staying in the hospital on average for 2 full weeks. And this is an extraordinary amount of time for an acute care bed. This really underscores how sick patients are, how much care they need to safely be discharged, and of course, how much healthcare resource utilization patients with cirrhosis do require. I now want to give you an overview of treatment of common liver diseases. As I alluded to earlier, non-alcoholic fatty liver disease unfortunately has no known helpful pharmacological therapy at this time. However, there is room to be optimistic. Currently, there are 913 clinical trials going on, and we're in a mad search to find some therapeutic medications for our patients. We know that dietary changes and exercise are very, very important and may be very helpful. Losing as little as 5% of one's fat weight may help with this disease quite substantially. Of course, for end-stage diseases where patients have cirrhosis, liver transplantation is the only known treatment. For patients who do not have cirrhosis but have several obesity-related diseases, including fatty liver disease, if weight loss cannot be achieved through lifestyle modifications, consideration for bariatric surgery is very important. I now want to talk about the treatment of alcohol-related liver disease. And I can't emphasize enough that the single most important intervention we can make as healthcare providers is to link our patients to addiction therapy to help them achieve abstainment from alcohol. It's also important that we optimize nutrition We provide preventative treatments for these patients, for example, vaccinating them against hepatitis A and B so that they don't have any other factors which may produce liver failure. We know that for end-stage liver disease from alcohol, transplantation is very effective. Unfortunately, we don't have pharmacology available in this group of patients, although prednisolone is very helpful for patients with severe alcoholic hepatitis, although it must be used with caution due to the risks of sepsis that this type of medication may impose. Very briefly, hepatitis B and C are both easily treatable with oral medications, which have virtually no side effect. And I also want to emphasize that hepatitis B is fully preventable with vaccination. Thankfully, here in Canada, even though hepatitis C treatments are very expensive, we have broad access to treat any patient with hepatitis C. And what we're doing now, especially with the COVID pandemic, is wanting to re-engage our partners in primary care to continue to screen patients so that we can identify and treat as many patients as possible. I will briefly touch on autoimmune liver diseases. Previously, we used to think these are diseases which only affected patients of European ancestry, but we now know they're common in many other ethnic groups, including South Asians. Autoimmune hepatitis is a disease where the immune system is attacking liver cells. It's an easily treatable disease with corticosteroids and azathioprine. And there are two autoimmune cholangitic diseases, PBC and PSC. PSC, unfortunately, has no treatments, and clinical trials are now underway to find medications for these patients. Unfortunately, 50% of people with PSC may need a transplant in their lifetime. The diagram, I now want to mention very obviously that cirrhosis unfortunately has no medical treatment, and the only cure is a transplantation. As you know, transplantation can be done with a deceased donor, but also with a live donor. Liver transplantation is a very successful operation here in Canada. Over 600 transplants are done each year, about 20% of which are live donors. It's a major surgery. It lasts over 8 hours, and patients need to be selected very carefully so that we know that they'll have a high likelihood of surviving this very complicated surgery. Both recipients and live donors have excellent long-term outcomes. Unfortunately, transplantation is also a limited resource. For example, for patients awaiting a deceased donor, they may need to wait a long time, which is why we really want to promote live donor in appropriate patients so that wait times can be eliminated. In Canada, we use something called the MELD sodium score to prioritize the sickest patients to get transplanted first. Typically, patients stay in the hospital for 2 weeks after transplant and may be in the ICU for 1 to 3 days. Once they're discharged, they get very close follow-up with the transplant team. And after around 3 months, most patients are back to an excellent quality of life. I now want to close my talk just addressing prevention. We can do a lot of things together to prevent liver disease. Firstly, we need to work on education, basic education on optimizing our diets, on exercising. We need to make gyms and personal trainers and nutritionists more easily accessible, especially to patients who are marginalized or have low socioeconomic status. We also want to encourage more screening for liver disease. Additionally, we are missing an opportunity to educate our youth on the harms that alcohol may pose when it is consumed in excess. Finally, we want to work together to make all patients in Canada, including new immigrants and other marginalized patients, aware of transplantation and help link them to appropriate care when indicated. Thank you so much for your time today.
Thank you very much, Dr. Chandak. And we will come back at the end of this session for questions. I would now like to invite Sonali, who is a transplant social worker at the Ajmera Transplant Center, to talk a little bit about her experience working with liver transplant patients. Sonali?
Thank you, Paula. So just to give some context about who I am, I have been working at the Ajmera Transplant Center as the recipient transplant social worker for almost 14 years now. And so when we're looking in the context of the South Asian community, I've had many years of working with this population. As Dr. Chandok mentioned, many of our patients are presenting with NAFLD and alcoholic liver disease, amongst some of these others. So the pictures and the descriptors that Dr. Chandok provided are very typical to what I see when I see patients. I also am coming to this presentation today as a Canadian-born child to South Asian immigrants. So I have obviously not a full understanding of everything, but I do have a bit of a lens towards some of the populations that we're speaking about today. So my role as the recipient social worker, so the recipients are those who require a transplant, is to really meet with patients and families to learn who they are, where they fit in their family and their community, how their illness is impacting their life, their family's lives, to provide information and education, and to provide support. This, any new or chronic illness is an adjustment for individuals and families. The idea of transplant is also a very overwhelming piece of information to deal with. So I often will talk with patients about how they're managing these kinds of things. I wanted to add this Determinants of Health slide as a bit of an introduction. It is, social determinants of health is a presentation in and of itself. So I'm not going to go into a lot of detail here, but it does speak to some of the barriers that individuals will experience in accessing healthcare. And I look at this slide, and for the context of this presentation, I tried to break down the South Asian community into kind of 4 general categories. Now, these are not exhaustive, but kind of populations that I have seen in my practice, and trying to put some context to what I'm going to speak about. So the first group are sort of an older South Asian population. They're about 60 or 70. They were probably the first in their families to emigrate to Canada, coming as young adults to start their families and their careers. Their first family, if you will, were probably community members as opposed to biological family members. Their children now as adults may be scattered around the world because, for work and families. Then you've got sort of some young and middle-aged South Asian populations, emigrated to Canada, sponsored older parents. They may have children who are younger, born here, or who emigrated with them, and more of a multi-generational family situation. Then you have an even younger population of individuals who are coming here as students, or who are coming here to work. They may be married or single. Again, limited biological family connections here, may or may not rely on their communities, if those communities exist, for support. And then the last group kind of are those like me who are born and raised in Canada, and we're the children of the primary, that first group of people, or the second group. So the group who emigrated many years ago, or the group who are now sponsoring our family members. So just to give you a sense of what social determinants of health are, and to perhaps place yourself, depending on what situation you have come to Canada as, or whether you're born here, to give you a sense of the social determinants of health. Paula, could you advance? Thank you. Social determinants of health refer to a specific group of social and economic factors within the broader determinants of health. So these relate to an individual's place in society, such as income, education, or employment. So the Government of Canada website, when they talk about social determinants of health, comment that the experiences of discrimination, racism, and historical trauma are important social determinants of health for certain groups, such as Indigenous peoples, LGBTQ, and Black Canadians. And I would argue that the definition also applies to a multitude of groups, including other ethnic populations, ethnic minorities, and new immigrants. So looking at all that. So I want to just break it down a little bit to help you understand how this translates to accessing care. So in its first instance with health insurance, if you're a new immigrant to Canada, if you're a population, if you're an individual who's been here for a long time, these issues may have been resolved, but may have been something you dealt with when you first came. But for new immigrants, health insurance, OHIP takes 3 months to have in place once you have landed in Canada. So just accessing basic healthcare is delayed from that. Housing and employment, we are seeing people who are underhoused and underemployed as new immigrants. Some of our patients have medical degrees, or they're medical trainees in their country of origin, and when they come here, their credentials aren't immediately recognized, so they are doing other jobs while they work towards that. Food and healthy lifestyle knowledge. Dr. Chandok alluded to this, that there is sometimes a knowledge piece that is changing or not available in terms of how good food is important, but also accessing that food is expensive and can be impacted by your circumstances. Language, if you don't speak English, if you don't have access to somebody who speaks English, navigating any system in a new country can be very challenging. Added to that, if there's a health issue or limited support, you're adding layer upon layer. Health literacy is a similar piece. If you don't understand, the definition of health literacy first is the ability to access, comprehend, and evaluate and communicate information as a way to promote, maintain, and improve health in a variety of settings across the life course. So this could be, a challenge with health literacy, could be language, could be low literacy, any number of things. And then support, whether it's biological family, community, it's depending on when you came to Canada, depending on what your networks are, support is either in abundance, or there is a huge lack of support, and trying to find that support can be difficult. So how this sort of just translates very briefly to diagnosis, we're waiting for 3 months for OHIP to kick in if you're a new immigrant. And I should preface this with, this is not going to be the experience of everybody. This is more the experience of certain populations, but we do see this within our South Asian community. And so that's why I speak to this, but we also see very successful immigration stories and patients who none of these issues have been problematic. So access to diagnosis, if you're living paycheck to paycheck, you have a fear of job loss if you take time off to get to investigations. Hopefully you have a doctor. If there's language barriers, there's difficulty in articulating your symptoms. As Dr. Chandok mentioned, the initial symptoms of liver disease can be very not sort of specifically identifiable or easy to overlook. So it takes that much more time to get to a diagnosis. I also find there's a big dependence then on others. If you are fully dependent on a family member or somebody else to get you to appointments or to communicate on your behalf, you're fully in that person's hands to get you to the care that you need when it's needed, when it's appropriate. So you lose your independence with that. And then the next layer is the access to a specialist. So at the point of diagnosis, if things really get bad and patients end up in the emergency department with a sudden onset of symptoms, they're not always referred to a community specialist from the inpatient side. Hopefully they are, but sometimes it's referred back to a family doctor to then refer to a specialist. Again, we come back to language, being able to speak to a specialist about what your symptoms are. I think there is a need in the community, if you are lucky enough to be connected to a specialist who understands your cultural and ethnic specific norms within your community, it can be a lot easier to communicate and make changes. Whereas if you're in a community where there are not a lot of specialists who understand where you're coming from, there can be more challenges. And sometimes people can be labeled as non-compliant or non-adherent when it is a lack of understanding or a lack of having the right ethnic or cultural resources to help them through the issues that they're dealing with. And then we come to transplant. And so accessing transplant, it's a complex medical care management, and sometimes very difficult to understand without interpretation services. We're very lucky at UHN to be able to access many different interpreters with different language backgrounds. So we don't need to rely on family to interpret. And I'll come back to that as an important part of what I do in a moment. We talked about lifestyle factors being hard to maintain on limited income. When you get to a point where you have a major liver disease and some of these lifestyle changes are necessary, having the information and the resources to make those changes is very important. We also see that some of these lifestyle factors can be generational, so that can impact finding a living donor, among other things, and I will come back to that again in a second. Access to a transplant center. There are 2 in Ontario for liver, in Toronto and London. So just physically getting to those centers can be a challenge. Again, goes back to language, finances, support, lots of areas. And then the last point here is non-compliance at the specialist level, perhaps due to a disconnect, not always, but can be labeled as being not a good candidate for transplant and therefore not referred to the program. So these are some of the experiences that I have heard from my patients when they come to see me. So how do these factors relate to transplant? So by the time you get to transplant, your health insurance should hopefully be sorted out. We do have some people who are here as refugees or on work visas, and things fall apart in the interim, so we need to sort that out. But for the most part, our patients in those categories those 4 groupings that I labeled at the beginning, usually sorted out. Housing is so unique to each individual. You may have a very stable housing situation, multi-generational, or living independently on your own, very comfortably, underhoused. It may continue to be that way throughout the transplant process. Employment and income, the same thing. The pieces that I think are really key to understanding within transplant are that food and healthy lifestyle knowledge, language and literacy, and support. So I feel that our transplant program really is able to bring an understanding of the ethnic and cultural norms of different groups. And if we don't live that experience ourselves, it's an understanding that they exist and a willingness to work with our patients to try to find a happy median. So we know with food, Paul, if you could go back just one. With food, we know that it's very specific, and it's difficult to give up our foods that we love. In the South Asian community, there's very specific foods. And so working with these populations in a culturally sensitive way to understand first, the impact of giving those up. Second, what the need is to give it up and why that's important. And then thirdly, working together to find a plan that is sustainable and manageable for both parties. Language and health literacy. I wanted to just give an example here of how interpretation services is so important. I had a patient some years ago. She was an older lady from India, did not speak any English, and was sponsored here by her son, who was her primary support person. Her daughter-in-law did not work outside of the home and was at home to provide support. The patient's son was the primary earner and sort of the driver. And so the whole transplant process was really moved along by her son, who often provided interpretation, and she came along with it without any fuss. And so there was an assumption that she was on board with transplant and willing to go ahead. For the social work assessment, because we always have a third-party interpreter if we are able to have that in place, she was asked very specifically whether she wanted to go ahead with transplant, and she flat out said, no, I don't. She felt that her life was comfortable as it was. She didn't want to burden her family, and she just didn't want to proceed. And so there was further conversations with her from the medical team, and she continued to refuse to have a transplant. And so we did sort of stop that evaluation in deference to her wishes. but it just shows how important that interpretation and that third-party interpretation can be when you're talking about major things like a surgery and these kind of lifestyle changes and lifelong implications. And then just to support, again, language is a big piece. I think multi-generational families can be very helpful in some of our patients. And we have seen families where it's a bit more traditional in that, I say traditional, but with sort of a knowledge of where gender relations and gender roles are very specific. So you'll have, as I mentioned in this last case, the son was working, the daughter-in-law was at home to provide support. So sometimes in those situations, the multi-generational family is very helpful. In others, it can be problematic if the older relative is a caregiver to their grandchild. And so those dynamics then become complicated. The entire family system begins to unravel a little bit with the health decline. And then I think one of the advantages that I've had in working with this population is understanding the role of community as a surrogate family, and if that community exists, the advantage and the support that can be offered from these communities, and recognizing that when a patient comes to me and says, I have lots of community members who can support me, or when they show up with people who are not biologically related, recognizing that that is a very important part of their support network. And the one other piece that I wanted to touch on was living donation. Obviously, we're a transplant center, and liver transplant is available as a deceased organ transplant or as a living donor transplant. It's important to note that the South Asian community leaders and religious leaders are very much in favor of organ donation. But I have seen in my population, my patient practice, that some of the older generation people who need transplant do not want their children to donate for them. They don't want to put that burden on them or put them in harm's way. As we talked about with the financial implications, sometimes the option of donation is a challenge. From genetic risk factors, sometimes that excludes people who are willing to donate. And in transplant, my role is never to convince anybody to proceed with donation if they don't want to, but I can certainly provide some direction and education around the different perspectives in order to support that conversation. And I have heard from my living donor social work colleague that there are, in her experience, many South Asian donors who go ahead to donate to a family member or community member. So my experience with that hesitation clearly changes as you go forward, and there's more discussions that can be had. So really, just to summarize, I think the biggest barriers to transplant are language and health literacy, and the limitations for social support. But I think, in my practice, I've always strived to help people find those relationships and find those resources however they can find them. And I think that's really an advantage of our transplant program, but that subspecialized care as well. And I just want to say a quick thank you to a few of my colleagues who gave me a little bit of background. Mridula Suri was our former ambulatory transplant nurse who had a lot of insight into this patient population. My spiritual care colleague, Stefan, gave me a little bit of the insight into the religious understandings of transplant. And then my colleague, Laura Middleton, who is the living donor social worker, gave me a bit of insight into how the living donor process works in this population. So thank you.
Thank you very much, Sonali. That was a great overview, and I think you've touched on a number of issues that will likely come up during this next portion of our webinar, which addresses questions submitted in advance and submitted via Slido. So for those who are participating live and you have a question, please visit slido.com and enter event code liver health. That's slido.com, event code liver health. And so let's see some of the questions that have been submitted. And it looks like these first three questions might be for Dr. Chandok. Is fatty liver reversible? And what is the impact of this disease on the South Asian communities? This was, these topics were, covered by your presentation, but it is important to potentially emphasize some of the key messages that our audience may benefit from hearing again.
Excellent questions. And I must say, questions that I get asked every single day. Fatty liver is theoretically reversible. Research has indicated 10% of weight loss is usually associated with a significant improvement or reduction in fatty liver, and potentially an improvement in liver fibrosis. Fibrosis means scarring. The only thing I would say is that I want to make one point. There are actually many causes of fatty liver. I didn't mention that, but I think this question is implying non-alcoholic fatty liver disease. I also want to mention that some of this disease is genetic, as I alluded to. We can't change our DNA, but for the vast majority of patients, they can improve their health with regard to liver, fatty liver content by weight reduction. Weight loss is very, very difficult, but I usually ask my patients to begin an exercise program, 30 minutes a day. I ask them that when they're exercising, by the end of the session, they feel sweaty. That means they've burned a lot of calories. And I ask them when they're making dietary changes to focus on reducing caloric intake, but specifically reducing the amount of refined carbohydrate in the diet. So these are foods like rice, roti, bread, cereal, sweets, anything made of grain, flour, or sugar. And pertinent to the South Asian community, there's a lot of people who are vegetarian. And I think it's particularly challenging in that group to reduce carbohydrate because they don't have as much protein to fill their plate. So I do stress in them optimizing their vegetables and fruits and just trying their very best to reduce the amount of refined carbohydrate. So yes, it can be improved upon. This is a disease, as I alluded to, that has a tremendous impact on South Asians. And based on what we can gather on epidemiological research, South Asians appear to have much more fatty liver than other groups. So we really need to focus on why that is. If we can't change our DNA, at least not yet with modern science, we need to look at what we can optimize. So we can definitely optimize our exercise and definitely look into how we can adjust our diets.
Thank you very much, Dr. Chandok. There is a question here about diet. You've mentioned some approaches that may be helpful. There's been also questions around high protein diets, et cetera. So can you comment on an alkalizing diet or high protein diets or other types of diets that our patients often ask us about? In response to this question?
Absolutely. So the short answer is that there is no one diet that's superior. So the diet that I advise my patient is the diet that works for them, that facilitates weight loss. So in some patients, it may be a trial of a keto diet, or it may be a Mediterranean diet, or it may be retaining a South Asian diet, but making some tweaks to it. Many patients may also find success with intermittent fasting, and that may be a particularly good option to try if someone is vegetarian and is having a struggle to reduce refined sugars. So there's no diet in the medical literature that's noted to be more favorable over another diet for liver health. But generally speaking, optimizing plant intake, so fresh fruits and vegetables, making sure we're getting lean sources of protein in our diet. This could be eggs, fish, beans, tofu, etc., and really reducing the refined sugar. One of the other questions I get asked is, do I need to lessen my fat intake if I have a fatty liver? And the answer is not necessarily. So fat in our diet does not cause a fatty liver, it is sugar. And the medical word for sugar is carbohydrate. So just remember that. Vegetables are very good carbohydrates because they're full of fiber and nutrients. But something like bread is basically like having raw sugar when we metabolize it, or rice. It's a simple carbohydrate. As soon as we eat rice, it turns into sugar in our bloodstream. So we really want to focus on those refined sugars and reduce them. For some patients, it's something they would do gradually. But for the person who asked this question, one need not have a very stringent diet, but I think it's important for an individual patient to trial and error different diets, because patients will often find that one strategy works really well for them over another one. I do want to make one point, and that is we must also get these patients engaged with exercise. For people who have fatty liver disease, the number one cause of death is actually not liver disease. It's actually heart attack or stroke. So it's really important that we have that patient engaging in aerobic exercise to protect themselves from getting a cardiovascular event.
Thank you very much for that. And you mentioned intermittent fasting. Can you clarify what that is?
Absolutely. So intermittent fasting is quite popular nowadays. It may not be for everyone, and one should consult with one's primary care practitioner to make sure that it's appropriate for them. Intermittent fasting refers to a change in when we consume calories. So a typical program may be that one would eat from, say, 12 noon until 5 p.m., a healthy, balanced diet, and after 5 or 6 p.m., not consume calories again until the following day at noon, so that their body is having a prolonged fast. And what happens during this fast is we are able to lose weight. We end up eating less calories in a day. And I must say, many of my patients, even though it sounds rigorous, many of my patients love this. They feel more invigorated. It does take time to get used to it, but it's something that I'd encourage patients who want to explore that to also look intermittent fasting up online at a reputable website, and you'll get all kinds of different strategies to practice intermittent fasting. But it may be an excellent option. And as I said, I find it a particularly good thing to try for patients who are vegetarian, and it's really hard for us to optimize their protein.
Thank you very much. Sonali, perhaps I'll direct these next couple of questions to you. We've got a few minutes left. I'm wondering if you could talk at a very high level about what happens when patients are referred for transplant. What does the process look like at a very high level? And then for those who have questions about living donation, what happens at the very high level?
So when a community hepatologist or a community GI specialist refers to the transplant program, they are first seen by a transplant hepatologist, transplant liver specialist, to make an initial consideration for whether they meet the basic medical need for transplant. From there, if it appears that transplant is the best option, they are then put forward for a more thorough evaluation of all of their organs to make sure they are healthy and that transplant is a safe option for them. And the evaluation also involves social work, anesthesia, if there's a need for cardiology or respirology, so heart specialists or lung specialists, then that is also part of the evaluation. But it's really an overarching, thorough evaluation of your overall health to make sure that transplant is the best option for you and that it is a safe option for you. In terms of living donation, so the Center for Living Organ Donation does provide some support around helping families find a living donor. They aren't able to get the living donors for you, but they can give you some strategies around different ways to search for a living donor, different ways to talk to your family and friends about living donation, and work with patients and families around that, including a champion program, which identifies a specific person, not the patient ideally, identifies a specific person who could be the liaison with in that conversation.
Mm-hmm. Thank you very much for that. And this living donor candidates go through a similar assessment process.
Yes.
With recipients, we want to ensure that it is safe for them to donate. And so there is a team that assesses them and provides them with information that they need to make an
Absolutely.
decision.
Yes.
So very important. Dr. Chandak, the question of how you know you're on the liver transplant list seems to be a question that comes up often. Could you talk a little bit about the criteria for being on that list? What happened? How do you know when you're off? How do you know when you're active? How long does it take to work your
Absolutely.
list?
So a patient would be told by the liver transplant program if they are active on the list, and they would get regular appointments at the transplant program, and the transplant program would continually be updating the status of that patient. So as I alluded to earlier, transplant programs would be collecting data on their blood work, and there's a calculation that's done to prioritize patients on a list. It's called the MELD sodium score. And the various blood tests that are involved with this logarithmic calculation are updated by the program. And the transplant program would then, have a list. There's actually a provincial list between both programs. And it would be crystal clear to a patient if you are listed. So you will be told in verbal form and written form that you are active on a list. The transplant program would also communicate with the referring hepatologist or gastroenterologist, so we can also help be part of the external team. Patients may wait variable amounts of time. So remember that the sicker one is, the higher they are prioritized. So let's say we have a patient who is on the list, but they're not as terminal as somebody else. That healthier, quote unquote, patient will be waiting longer. So wait time is determined primarily by the severity of disease. There are other factors though. One's blood type may be a factor. How many other patients in your blood group are on the list may also be a factor. And it's important that in patients, especially lower on the list, that we do inform them about an option of live donation. So live donation eliminates wait time, and it's something that we would want to advocate to a patient if that's an option for them. Remember that for every patient transplanted in this country, there's a patient waiting. And we know patients do die on the wait list, which is why we want to make sure they're selected very well, and that we also promote live donation so that we can save more lives collectively.
Thank you very much, Dr. Chandak. We have many very important questions. Unfortunately, we've reached the end of our time today, but we will be addressing these questions in upcoming webinars. We have regular sessions, regular webinars that are presented by the Center for Living Organ Donation. Please visit our Eventbrite site, which is givelifeuhn.eventbrite.ca to view some of the upcoming sessions. You can also visit us at UHN Transplant or livingorgandonation.ca. One session that I particularly want to highlight is a session on the COVID-19 vaccine and patients with organ failure or who may have had a transplant. This is a series that we have on a monthly basis. The first one happened a couple of weeks ago, and we have one coming up at the end of March. I recommend that anyone who's interested and has questions about the COVID vaccine, that you submit those questions and that you join us for that webinar. I'd like to thank all of you for joining us today. A recording of this webinar will be available on the Center's YouTube channel, and it will also be captioned in a number of languages. Thank you for joining us, and we'll see you at the next webinar. Thank you.